Welcome. My name is Dr. Scott Kilpatrick. I'm a staff pathologist here at Anatomic Pathology at the Cleveland Clinic with a subspecialty interest in bone and soft tissue tumors. I would like to talk with you today about a particularly difficult topic, osteoblastic lesions. Like many areas of surgical pathology, it's relatively challenging, but it's mainly challenging because people don't see enough of these lesions to become proficient at it. So it's my goal today to try to talk to you a little bit more about these lesions so that your comfort level for establishing the diagnosis goes up. So what are the questions we want to answer today? Well, we want to talk about the difference between osteoid, osteoma, osteoblastoma, and of course its malignant counterpart, osteosarcoma. We want to talk a little bit about malignant osteoid, how we define that, and I want to stress the importance of radiographs in the interpretation of these lesions, but for all practical purposes, in all bone lesions. Now, when we talk about osteoblastic lesions of bone, there are many different tumors that can produce bone. But I want to specifically stress these three categories: osteoid osteoma, osteoblastoma, and osteosarcoma. So let's talk a little bit first about the benign lesions, osteoid osteoma and osteoblastoma. Both of these lesions predominantly occur in children and adolescents. However, osteoblastoma is more likely to be seen in adults than osteoid osteoma, so it has a wider age distribution. In both cases, patients typically present with pain, but osteoid osteoma has a fairly specific pain course, and that is it's generally pain that becomes progressively severe, and it's often worse at night and relieved by aspirin. Both are localized pain in general. As far as anatomic sites where these lesions occur, there's a significant amount of overlap. Both of them typically involve the long bones of the extremities. Both of them can involve the spine. But you never see osteoid osteoma in the craniofacial bones. This is really where osteoblastoma predominates. So a lesion with the features of either of these tumors in the craniofacial bones is almost certainly osteoblastoma. Another important distinction is the size. Osteoid osteomas are typically less than a centimeter, certainly no more than 1.5 centimeters. Osteoblastomas are almost always greater than 2 centimeters, so they're larger lesions. Now, if you look at the radiographs of osteoid osteoma, this is a typical feature of osteoid osteoma, is that they often form intracortical lesions, well-circumscribed sclerotic, what we sometimes refer to as nidus, that's frequently surrounded by dense sclerotic bone. Very benign type of appearance. Again, these are small lesions. I have seen cases in which the sclerosis is not particularly predominant, but in most examples of osteoid osteoma, they can be recognized radiographically. Osteoblastomas, on the other hand, are a much more complex lesion. They're larger lesions. They can produce large lytic lesions. Most of the time, as you see in this radiograph, they're fairly well circumscribed. You don't see permeation of adjacent bone in osteoblastomas, but they can on occasion show aggressive features, which can add to the challenge of establishing the diagnosis. Both osteoid osteomas and osteoblastomas show this pattern. That is, they're anastomosing bony trabeculae, which are basically rimmed by very prominent osteoblasts. Occasional osteoclast-type giant cells are present. An important point about these lesions is that the cellularity is typically prominent around the bony trabeculae. As you see here, a nice prominent osteoblastic rimming. But if you look in the spaces between the bones, the bony trabeculae, these so-called intertrabecular spaces, these are usually hypocellular and hypervascular, and we'll talk about that a little later as an important point in distinguishing these lesions from malignant osteoblastic lesions, namely osteosarcoma. This is just a little bit higher power view of the same thing. Nice rimming of very uniform, prominent osteoblast, and then when you look in the intertrabecular stroma, it's mainly composed of a few fibroblasts and blood vessels. You don't see these same cells populating the intertrabecular spaces. Now, on occasion, these lesions can become quite sclerotic, particularly towards the center of a nidus and an osteoid osteoma. And in these cases, basically, you're going to only have a small peripheral rim of osteoblasts with very little intervening stroma. Now, one of the other important points to make regarding osteoid osteoma, and particularly osteoblastoma, is these are not infiltrative lesions. So if you look down here, you'll see a rim of the native bone from which this lesion arose. And this lesion is nicely circumscribed. It doesn't permeate the surrounding bone. And that's a very important point. Permeation almost always is indicative of malignancy. Now, there have been described in the literature osteoblastomas with some atypia in the individual cells, as you see here, in large cells, sometimes having smudgy chromatin. This is probably analogous to the ancient changes that we see in nerve sheath tumors. It's a totally benign process, but it's just something to be aware of. Again, notice intertrabecular spaces do not show a population of osteoblastic cells, but instead are very hypocellular. Now, what about malignant transformation of osteoblastoma? It's sort of my opinion that most cases of malignant transformation of osteoblastoma were probably osteosarcomas to begin with, but you will see this term used synonymously with these designations here. I think in most cases this diagnosis can be separated out from osteosarcoma, but you should be aware there are cases in the literature that talk about malignant transformation of osteoblastoma. It may exist, but in most cases, unfortunately, I believe they're misdiagnosed cases of osteosarcoma. So what are the helpful histologic features that we've mentioned? Well, for one, solid proliferations of osteoblasts within the intervening trabecular spaces is really indicative of osteosarcoma. Two, mitotic figures for the most part tend to be rare in osteoblastomas and osteoid osteimas. So if you see mitotic figures, you need to consider that this may be an osteoblastoma-like osteosarcoma. And third, as we mentioned, osteoid osteomas and osteoblastomas are well circumscribed lesions. You should not see permeation of bone. Unfortunately, there are no foolproof histologic features that always separate these lesions from one another, but generally if you correlate the radiographs and you understand these histologic discriminating features, you'll be able to separate these lesions in the overwhelming majority of cases. Now, briefly, I want to talk about osteosarcoma. And I think this is a very good definition that came from seminars in diagnostic pathology way back in 1987, but this designation really hasn't changed. Osteosarcoma is not a single entity, but is a family of diverse diseases in which the production of osteoid in our bone is a single unifying thread common to all. This means that osteosarcoma probably has the most heterogeneous pattern or patterns than any other bone tumor that we will discuss today. This is classic osteosarcoma. It's a fully malignant lesion, as you see here, that produces osteoid. That's the definition. It can produce only 1% of the volume of osteoid, or the whole tumor can be almost entirely composed of osteoid. It doesn't matter. The definition is malignant tumor that produces osteoid. So there are a variety of osteosarcoma subtypes. We're not going to talk about all these today. I'm mainly going to concentrate on these high-grade osteosarcomas and emphasize their distinction from one another, as well as from the benign tumors we talked about, osteoid osteoma and osteoblastoma. So osteosarcoma radiographs looks malignant, right? And you see that here. This is a lesion that basically has clouded out, if you will, the metaphyseal region of this proximal tibia, and you even see soft tissue extension as well. The borders are not well defined. Again, in the proper context, this is virtually diagnostic of osteosarcoma. Now, as I mentioned before, osteosarcoma is defined as a malignant tumor that makes bone. And for that reason, that means it can produce other matrices as well. And just to show you some examples, this is chondroblastic osteosarcoma, and you see a little bit of osteoid over here, but you also see the chondroid matrix, and here is the malignant spindle cell component over on the right side. One of the more typical features of osteosarcoma is to look like what we used to call malignant fibrous histiocytoma, very atypical pleomorphic spindle cells, atypical mitotic figures. This can predominate in the lesion, and again, as I mentioned earlier, osteoid production may be minimal, in which case you could classify this as a fibroblastic osteosarcoma. I should say up front that the subclassification of conventional osteosarcomas into fibroblastic, chondroblastic, osteoblastic types has no bearing on the therapy and very likely no bearing on the prognosis as well. Osteosarcomas can be predominantly small cell varieties and can be confused with Ewing sarcoma. Notice here these big nodules of chondroosteoid material and these small round tumor cells that, taken out of context, look a lot like a Ewing sarcoma. And this is just a little bit higher power view of some of these cells. Osteosarcomas can be composed of an abundant giant cell population and confused with giant cell tumor. In these cases, it's important to pay close attention to the intervening stromal cells that are present. And this is where you'll find the atypia that's virtually diagnostic of osteosarcoma. Osteosarcomas can also be predominantly bone forming. This is the native bone in the patient here, and the tumor, as you see here, is producing large amounts of bone and permeating or infiltrating the adjacent bony trabeculae. And this can be a very difficult diagnosis to establish on a small biopsy because you'll notice there's very little atypia to this lesion. These osteoblastic or sclerosing osteosarcomas behave just as aggressively as the more atypical types of osteosarcomas. Osteosarcomas, as we alluded to earlier, can also resemble osteoblastomas. You see this process here. Here's malignant osteoid between and lined by osteoblast, but what do you notice is that there is no intervening stroma between these osteoblasts. It's gone. So these types of features are really indicative of an osteosarcoma and not osteoblastoma. This is a little bit higher power view just showing these epithelioid osteoblasts, which are remarkably uniform. As I mentioned earlier, mitotic figures generally rare in osteoblastomas, almost unheard of in osteoid osteomas. So if you see a mitotic figure, it's really indicative, or at least it should strongly suggest the diagnosis of osteosarcoma. Now lastly, I want to mention one tumor that I have seen show up in medical legal environments too often, and that's telangiectatic osteosarcoma. Telangiectatic osteosarcoma is really not in the differential with osteoblastoma and osteoid osteoma, but it is a form of osteosarcoma that can be missed if one doesn't pay particular attention to the radiographic and morphologic features. The classic presentation of telangiectatic osteosarcoma is that of a lytic lesion, as you see here, almost purely lytic, no dense osteoblastic features on a radiograph. Very ill-defined borders, often has periosteal reaction, may even have a soft tissue mass, and the big diagnostic dilemma in this lesion is separating it from aneurysmal bone cyst. And if you look at low power, you can see why. Basically, these are septa that surround blood-filled spaces. Low power, if someone showed me this case, I'd call it aneurysmal bone cyst. The difference is when you go down and you look at high power at these septa, this is where you see the atypical cells that define telangiectatic osteosarcoma. You should never see this type of atypia in an aneurysmal bone cyst. So this finding is virtually diagnostic of telangiectatic osteosarcoma. Bear in mind that this tumor may have very minimal osteoid present, and therefore you'll be relying solely on the radiographic features and the finding of these atypical cells in these fibrous tissue, in these fibrous stroma. Here's an example of some of the osteoid at the edge of one of these fibrous septa that's being produced by the malignant cells. But again, very atypical cells are present. I have seen examples of this tumor in which the atypical cells were present on one slide out of about 20, and that was what helped establish the diagnosis. But I just want to bring this entity up because it really is an area that can result in a medical legal challenge. Thank you very much.